Wow, what a great symposium so far. Welcome back, everyone. I am now excited to introduce Dr. Jennifer Miller for our next session on dismantling health disparities by building trust in patient centricity and life science. I had the pleasure of meeting Dr. Miller a couple of months ago, and I'm just fascinated by her outstanding scholarship and leadership in this work. So I'm really thankful that she had the time to be with us today. So a little bit about Dr. Miller. So Dr. Jennifer Miller is an associate professor at the Yale School of Medicine. She's also president of the nonprofits Bioethics International and founding director of the Good Pharma Scorecard, an index that ranks biotechnology, pharmaceutical, and medical device companies on their bioethics and social responsibility performance. Dr. Miller's current research focuses on developing accountability metrics and policy guidance for responsible, trustworthy, and equitable biomedical research, healthcare data sharing, access to medicines and vaccines, and also the use of AI and ML, which is artificial intelligence and machine learning in medicine. Her work is supported by numerous grants, including from the FDA and NIH. Prior to joining Yale's faculty, Dr. Miller was an assistant professor at NYU School of Medicine and completed her training in physics, bioethics, regulatory governance, and ethics at the Fordham University, Regina Apostolorum, Duke University, and Harvard University. So now it's my pleasure to hand over the floor to Dr. Miller. Dr. Miller.
Thanks, Omar, for that generous introduction and for the opportunity to participate in today's symposium. Good afternoon, everyone. For those I don't know, I'm Jennifer Miller. And as Omar mentioned, I'm an associate professor at Yale School of Medicine and president of Bioethics International, a nonprofit I co-founded in 2005, and director of the Good Pharma Scorecard, an index that evaluates and ranks biotechnology, pharmaceutical, and medical device companies on their bioethics, patient centricity, and social responsibility performance annually, which includes a series of equity-related performance metrics. And today I'll touch on two of these key metrics. Next slide. Clinical trial diversity and equitable access to the benefits of research. Needless to say, these are necessary but insufficient elements on their own to advance patient centricity across the sector. Next slide. Let's begin with clinical trial diversity. There is widespread consensus on the need to improve diversity in clinical research. Countless studies have shown women, older adults, and some racial and ethnic groups are often underrepresented in clinical research. In other words, we tend to test drugs on healthy, young, white identifying males who don't necessarily represent the patient populations who ultimately will use a drug. Next slide. Our own study published in JAMA Network Open last year also showed this. We evaluated transparency and demographic representation for a sample of novel cancer therapeutics approved by the FDA between 2012 and 2016, evaluating their pre-marketing and post-marketing studies. We looked at two main outcome measures. First, the transparency of patient demographic information. That is the percentage of pivotal trials with public information on trial participant demographics. Could we tell the sex, age, and race ethnicity of trial participants? And the second main outcome was demographic representation, the percent of trials where participant demographics represented at least 80% of the demographics of patients with the condition or disease targeted by a study. Evaluating FDA approvals from 2012 to 2016, which was 45 novel cancer therapeutics based on 77 pre-marketing studies with 56 post-marketing studies, we found low transparency, which generally got worse for post-marketing studies for sex and race. In terms of pre-marketing pivotal trials, while 100% were public about the sex of trial participants, only 48% of pivotal trials had public information about participant ethnicity, 77% age, and 81% race. These numbers went down for post-marketing studies. Only 75% of post-marketing studies had public information about the sex of trial participants, 30% ethnicity, 48% race, and 64% age. Next slide. When you could tell the demographics of trial participants, we benchmarked representation. While we found that women were adequately represented in pre- and post-marketing studies, older adults and Black identifying patients were underrepresented in pre-marketing trials and continue to be underrepresented in post-marketing studies. This is a social justice and public health problem. Next slide. As our team wrote in the Journal of Medical Ethics this year, 2022, along with Tanvi Varma, Camera Jones, and Carol Oladele, underrepresentation challenges clinicians, payers, and patients' abilities to apply study findings to excluded or underrepresented demographic groups in trials, and exacerbates disparities in access to the benefits of clinical research, notably equitably assessing the safety and efficacy of novel therapeutics for all patients who will ultimately use them. Next slide. While the barriers and facilitators to trial diversity are widely documented in the literature, disparities persist. Documented barriers include the use of overly restricted inclusion and exclusion criteria in protocols, which exclude patients with certain comorbidities and concomitant medication use, for example, which can particularly limit the number of older adults who qualify for trial participation. And this is despite certain conditions like cancer incidence increasing with age. There are also many blanket exclusions for conditions such as high blood pressure and depression. Other factors include limited access to healthcare, limited access to transportation and childcare needed for trial participation, interpersonal discrimination. There's some evidence showing that researchers and clinicians can be less likely to discuss trial participation with Black identifying patients, and distrust in the research enterprise. These and other factors can exacerbate demographic disparities in trial enrollment. Next slide. Along with well-documented barriers, policy efforts to improve trial diversity span decades, still with limited impact. Currently, the US Senate is considering legislation which was passed in June 2022 by the House of Representatives, which would require research sponsors to develop and submit diversity action plans for their phase 3 and pivotal trials supporting their product approvals, which would detail enrollment goals disaggregated by age group, sex, race, geographic location, socioeconomic status, and ethnicity, along with rationales for each goal and details on how sponsors intend to meet the goals. The bill would also require the Secretary of Health and Human Services to consider mandating post-approval studies or post-marketing surveillance if sponsors' pre-market trials fail to collect sufficient data on underrepresented groups as defined in their diversity plan. If passed, this legislation would codify the recent FDA draft guidance to industry released in April of 2022, similarly recommending industry develop and submit race and ethnicity plans to the FDA for its sponsored trial. This FDA guidance expanded its previous recommendation to merely collect race and ethnicity data on trial participants to now include an expectation to set concrete enrollment goals for underrepresented populations for trials intended to support product approval. These are on top of previous legislative and policy efforts, including the NIH Revitalization Act, signed into law in 1993 and revised in 2017, which directed the NIH to ensure minority groups and women are included in clinical research, 21st Century Cures Act, and the list goes on. Next slide. New ideas and new reform strategies are needed to address this public health and social justice problem. And one idea is to introduce a scorecard, a rating and ranking system to evaluate sponsors regularly on their trial diversity performance. Next slide. Studies have shown publicly rating and ranking companies can be an effective quality improvement strategy. Here on the screen, you can see one study by Chatterjee and Topol, conducted when they were at Harvard and Duke, which evaluated almost 600 firms subject to environmental ratings and found that low-scoring firms substantially improved their practices and procedures in response to being rated and receiving a low score. And as I mentioned earlier, I run the Good Pharma Scorecard, and we found these types of rating and ranking programs have similar quality improvement power. Next slide. So what is the Good Pharma Scorecard? The Good Pharma Scorecard, or GPS for short, is an index designed to evaluate and rank pharma, biotech, and medical device companies on their bioethics, patient centricity, and social responsibility performance annually. The rankings are conducted by investigators at Yale University and Stanford, with findings disseminated in the peer-reviewed literature and in partnership with Scientific American, which lists an audience of greater than 8 million. Development was informed by a review of 75 of these types of ratings and ranking programs to implement best practices and avoid pitfalls. And all measures are developed through a multi-stakeholder process, which includes patients. Next slide. The Good Pharma Scorecard, like many scorecards and quality improvement initiatives of this ilk, help do 4 things: set and communicate clear goals or expectations for a sector, and then track progress annually using those goals that the scorecard sets, to recognize best practices so we can learn from them, figure out how they did it, and importantly, incent improved behaviors where needed. And the big punchline is these scorecards work. In terms of the Good Pharma Scorecard, half of the low-scoring large companies will improve procedures within 30 days of getting a low score, and industry scores are going up annually for all the measures we built into the scorecard. So why did we start the Good Pharma Scorecard? For all the reasons on the screen that I just mentioned in terms of quality improvement, but also, and importantly, to bridge asymmetries of information about the patient centricity of pharma companies. 20-ish years ago, while I was a student, I noticed the scholarly literature and the media coverage of the industry tends to be very negative, focusing on failures and scandals. And from the outside, it was not easy to understand whether cited scandals and the media coverage represented genuine, widespread, and current problems across the industry, or the behaviors of outlier companies in an otherwise sound industry, or rogue employees in an otherwise well-functioning company, or studies and coverage of old data and old problems that had since been reformed. And so the scorecard in some ways started as prevalent studies to determine what was going on within companies today. And also, next slide, to improve trustworthiness across the sector. Several polls and surveys have shown a lot of distrust in the pharmaceutical industry, despite widespread use of its products. Only 9% of Americans report trusting pharmaceutical companies are honest and ethical, and 91% think they put profits before people. Next slide. And in terms of other US business sectors, it ranks towards the bottom in trustworthiness. When a sector has too much distrust, when people don't trust it, it can lose its social license to operate, which can yield disengagement by stakeholders. And in this case, that can be a public health problem, manifesting in things like vaccine hesitancy or hesitancy to participate in clinical trials. And so I've been interested for the last 20 years in how we can rebuild trustworthiness and patient centricity into the sector. Not trust, just trust, but trust and trustworthiness, merited trust, not trust in a used car salesman who could sell you a lemon of a car. And catalyzing positive change we need as patients. So that's the origins of the Good Pharma Scorecard. And before debuting the new diversity measures that we just developed, let's review how the Good Pharma Scorecard works and some other measures, focusing on transparency and data sharing. Next slide. So the Good Pharma Scorecard is designed to comprehensively address the key bioethics, patient centricity, and social responsibility concerns about pharmaceutical companies, but we debuted publicly focused on transparency and data sharing in clinical research. And we did this, next slide, in part because there was already robust evidence suggesting a widespread transparency problem across the ecosystem in need of reform. Here on the screen, you see a study that was published in March of 2015 in New England Journal of Medicine by Rob Califf. I'm sure you guys recognize his name, and Monique Anderson, both of whom were at Duke when I was down there, and this study came out. And their study showed that only 20% of trials that are registered in clinicaltrials.gov have reported results by 1 year of their primary completion date. And even if you look at 5 years past their completion date, you're still only seeing about 50% with public results. And so why did we need to change this? Multiple reasons. I'll just mention 4. First, clinical trial transparency is critical for quality patient care and the practice of evidence-based medicine. Clinical trials contain the key evidence on drug safety and efficacy at the time of approval. Further, transparency is important for innovation, that is the development of new cures and therapies. Scientists need to learn and build upon the findings of other scientists that went before them. and for honoring and protecting research participants, as well as appropriately fostering trust in the sector. Next slide. A study by Pew found that 57% of US adults say they'd trust scientific research findings more if the researchers made their data publicly available. Next slide. So we set out to develop a set of measures that could be reasonably asked of pharmaceutical companies to address the transparency problem. And the four measures in the broad sense are looking at, first, whether all trials supporting a new product approval have public results, either reported in any clinical trial registry or published in the literature within 6 months of FDA approval of a product. And then a smaller sample focused on just the trials conducted in patients for the approved indication. Still a smaller sample just looking at legal compliance. Are trials registered and reported according to US legal requirements? And then a commitment to data sharing. Looking at whether companies have a policy to provide timely access to analysis-ready data sets and clinical study data reports upon request, and that their website clearly explains how such data can be requested. If you can go forward 5 slides, that would be great, to slide number 25. One more. Thank you. So I'm going to show you how the 2021 Good Pharma Scorecard transparency rankings worked. We've been ranking products approved by the FDA since 2012, but for today's purposes, I'll just show the 2021 rankings, which focused on novel drugs and original biologics approved by the FDA between 2016 and in 2017. Which included reviewing over 1,000 clinical trials, supporting 62 product approvals sponsored by 42 different companies. And what we found in the 2021 rankings is that on our all trials metric, companies conduct a median of 13 clinical trials for product approvals. So NDAs and BLAs have a median of 13 trials that the FDA reviews. And per product, 62% of these trials have public results within 6 months of FDA approval of a product. And 26% of companies are fully transparent, meaning that they provide summary results either in a clinical trial registry or in the literature within 6 months of FDA approval for all the trials in an approved NDA or BLA. So 26% of products are fully transparent. That isn't very high. So if one of the reasons is that companies are generally not committed to disclosing the results of all clinical trials. They're committed to disclosing the results of the trials conducted in patients for the approved indication, which is a much smaller sample. It's a median of 5 trials per product. So if there's 13 all in, the trials in patients are 5 of those 13. And then what you find is that a median of 67% of those trials per product have public results, and that 58% of companies publicly disclose the results of all of their trials in patients for the approved indication. Many of those trials are pivotal trials, so those numbers are still pretty low. And one of the reasons of why we don't see higher numbers is that legally in the US, companies are not required, or trial sponsors are not required, to disclose the results of all their clinical trials, just those subject to mandatory disclosures under FDAA and the final rule. And that's a median of 3 trials. So there's 13 in an NDA or BLA, 5 of them are in patients for an approved indication, and 3 are generally covered by US legal requirements per product. Still, you don't find full compliance. About 58% of products are fully compliant with the law and disclose results, and 42% of companies. In terms of data sharing, you find that about 26% of the companies we reviewed commit to sharing individual patient level data for all their phase 2 and 3 trials in accordance with our measures. In terms of meeting all of the measures, about 17% of companies do. Next slide. And when you drill down into the data, what you'll find is that large companies are far more transparent than non-large companies, driven by higher FDAA compliance, legal compliance, and better data sharing commitments. In terms of FDAA legal compliance, large companies have a median score of 100% versus non-large 57%. And in terms of data sharing, large companies score a median of 100% versus non-large 20%. So if we're going to be focusing our efforts on improving clinical trial transparency, we want to focus on the non-large companies at this point. With the Good Pharma Scorecard, we always focus on the leaderboard, recognizing leaders, showing it's possible to do better, and setting up studies for how to do it. Findings are suggesting we are having a substantial impact on the sector. Next slide. Supporting the old saw, what gets measured gets done. As I mentioned, 50% of low-scoring large companies will improve their practices within 30 days of getting a low score, and industry scores are going up annually in all the measures in the scorecard. And investors are starting to use the Good Pharma Scorecard in their strategies and in the ESG space. And we've begun back-testing the Good Pharma Scorecard, and preliminary findings suggest that there's alpha, meaning that if you were to invest in the Good Pharma Scorecard, either by longing the high-scoring companies and shorting the low-scoring, or just investing in the high-scoring, you'd outperform an equally weighted index of pharma companies like the NYSE DRG index of pharma companies. Next slide. So based on this evidence of impact, we expanded the scorecard to include other patient centricity measures, including trial diversity, and I'll walk you through these measures now. Next slide. So what does clinical trial diversity mean? It means a lot of things, but one aspect is representation. And there are two leading ways in the literature to benchmark representation in a clinical trial. You can either compare trial participants' demographics to a country population demographics, or to those of the US, to those of a country's patient population. We use that second method. We compare trial participants' demographics to US patients with the condition or disease targeted by a trial. This method was advanced by Dr. Rita Poon when she was at the FDA and published in 2013 in the Journal of Women's Health. And it's also in keeping with current FDA guidance and legislative efforts. Next slide. To use this method for calculating representation, you construct a participation to prevalence ratio, or PPR for short, which involves dividing the percentage of a particular population among study participants by the percentage of that particular population in the real-world disease population. So just a ratio. A PPR between 0.8 and 1.2 is generally considered good representation in the literature. So basically, you want to represent at least 80% of patient population on a particular demographic. Next slide. So we have a forthcoming study in BMJ Medicine. It's accepted with a what they call minor revision, although I think it's quite a substantial revision. And in this paper, we developed measures to score and rank sponsors on their fair inclusion of demographic groups in pivotal trials. And we focused on pivotal trials supporting novel oncology products approved by the FDA between 2012 and 2017. And we looked at 3 outcome measures. Again, the transparency, right? Whether trials publicly report participant sex, age, and racial and ethnic identity. Representation, second one. Whether trial participant demographics represent at least 80% of the US patient population for the studied condition. And then we created a composite fair inclusion score, which averaged the transparency and the representation score for each demographic. And we report results on the trial, product, and sponsor level. Next slide. So what you found is that between 2012 and 2017, the FDA approved 57 novel oncology products sponsored by 24 different companies based on 60 pivotal trials. Each product was approved based on a median of 1 pivotal trial, which enrolled a median of 345 participants, and all in our sample included 27,000 patients. Next slide. So the scoring system is 50% of your score is transparency and 50% is representation. Yeah, if you can advance 2 slides, please. Thanks. And so here's what we found. In terms of transparency on the trial level, 100% of trials were transparent about sex, 63% age, and 40% race and ethnicity. And then in terms of the product level, 100% of products, oncology products, were approved based on pivotal trials that were transparent about the sex of participants, but only 65 were transparent about the age and 42 about racial and ethnic identity of participants. On the company level, 100% of companies sponsored pivotal trials that were fully transparent about the sex of participants. 38% of companies were fully transparent about the age of trial participants, and 21% of companies were fully transparent about the race and ethnicity of trial participants for all their pivotal trials. In terms of representation, focusing on products, 79% of novel oncology products adequately represented women in their pivotal trials. 25% of products adequately represented older adults in their pivotal trials. And only 11% of products adequately represented racial and ethnic minorities in their pivotal trials. And on the company level, in terms of fair inclusion, which is the composite score of transparency and representation, what you found is that 63% of companies fairly included women in all of their pivotal trials. That means they were both transparent about the number of participating women and they were representative. They included them in proportion to their representation in the patient population. 23% fairly included older adults. 21%. Let me start over. 63% of companies fairly included women, 21% fairly included older adults, and only 4% of companies adequately and fairly included racial and ethnic minorities in all pivotal trials supporting their products. So the big takeaway from this is that there's significant room for improvement. And on the lower, it's your left side, you can see that the rankings, we can't publish them yet, but each company will be scored and ranked on these measures. We plan to repeat these measures every year in these rankings with the next sample, including 2018 and 2021 approvals, in order to incent change and track progress on these important goals over time. And we're adding more diversity measures, not just looking at whether the participation of females and older adults and Black identifying, Asian identifying, and Latinx identifying patients or Latinos. We're also adding a review of Indigenous and Native American representation, Native Hawaiian and other Pacific Islanders representation, as well as by disability, geographic region, and other variables. The good news is that some companies do score 100% on our measures. Next slide. So we have a new FDA grant to conduct a positive deviance study. We'll have a 10-year sample of performance, and we're going to identify consistent high-performing sponsors on specific equity measures to study what distinguishes them from their peers, to identify shared behaviors, strategies, and contexts that have enabled them to achieve consistent top performance. That is, we'll be studying how and why they got things right, to learn from their successes for successful implementation by the broader research community to produce similar results. So stay tuned. Next slide. That was a very US equity perspective. So I'm going to step back now and take a global health equity perspective. This study that our team published last year in 2021 looked at market access to medicines and vaccines among the low and middle income countries who hosted trials for their FDA approval. Our sample was novel drugs approved by the FDA in 2012 and 2014, sponsored by large companies. We wanted to know 3 questions. 1, where were novel drugs approved by the FDA in 2012 and 2014 tested for approval? That is, which countries? And how commonly and how quickly were these drugs approved for marketing in the countries where they were tested? And whether there were differences or disparities in how long it took for any marketing approvals to occur by country income level or geographic regions where testing occurred. So a bit about our sample. The FDA approved a total of 79 novel products in 2012 and 2014, 43 of which were sponsored by large companies, which was our sample, based on about 900 trials targeting 28 unique conditions. Each drug was tested in a median of 25 unique countries in addition to the US, so 26 countries total. Each drug was tested in a median of 20 high-income countries, 6 upper middle-income countries, 1 low-middle-income country, and 0 low-income countries. Within 1 year of FDA approval, only 3% of drugs were approved for marketing in all the countries where they were tested, which increased to 15% when you looked 5 years out, and it wasn't much different at 7 years. Next slide. Of the 70 countries that contributed research participants for FDA product approvals, only 7% got market access to the drugs they helped test within 1 year of FDA approval. And only 31% did so at 5 years post-FDA approval. And again, things don't look much different at 7 years post-approval. Access was better and faster in high-income countries. Next slide. By geographic regions, market access to medicines was lowest in African countries, nearly 0, followed by Middle Eastern countries. Market access was unsurprisingly highest in Canada and Eastern European countries within 5 years of FDA approval, followed by Western European countries and Oceania. Asian countries were towards the middle of the pack, as were Latin American countries. Note, I was born in Ecuador, so I was particularly interested in Central and South America, and they fell towards the middle of the pack. We know marketing access does not guarantee a patient can afford a medicine or vaccine, or that there is a reasonable supply of a medical product, but it is a critical precondition for access. And now we're also adding measures analyzing pricing. From an ethics perspective, it's considered exploitation if you go in and you use a population to test and develop a drug, and then you never provide access. So we're trying to call patients partners in drug development, which can't happen in this type of situation. Wrapping up, we repeated this study to look at access to COVID-19 vaccines recommended by the World Health Organization to see if they were authorized in the countries where they were tested and whether there was equitable dose delivery. Next slide. So what we found is that the World Health Organization listed 6 unique COVID-19 vaccines for emergency use. These vaccines were tested in a total of 25 countries as of September 7th, 2021. Most of them were high or upper middle income countries. Among the 11 high income countries hosting completed trials, 91% authorized the tested vaccine, and they received enough doses to vaccinate a median of 52% of their population aged 15 and older. In contrast, lower middle and upper middle income countries only received enough doses to vaccinate a median of 31% and 14.9% of their population 15 and older, respectively. So we found substantial inequities in dose deliveries and procurement. Next slide. Wrapping up. More inequities and patient centricity commitments are in need of attention in drug and vaccine research development and delivery, and we're sprinting to address them. These issues range from research and agenda setting, which conditions and diseases are we targeting in our studies and with our financial investments. There's a known mismatch in disparities between needed health research and development by the majority of the world's population and that which is undertaken currently in R&D. There's that old 1090 gap stat where only about 10% of the global R&D expenditures is used for research for 90% of the health problems of the world, those mainly affecting the poorer populations. Almost every decision point in a trial protocol has patient centricity and ethics issue, from site selection to the choice of inclusion-exclusion criteria and endpoint choice. There are known gaps in the US in terms of trial access. There are rural-urban gaps and community hospital versus academic medical center gaps. You're much more likely to be able to access a trial if you live on the coast in the US, rural areas, and near large academic medical centers. And I already showed you in terms of global access that we test most of our drugs in high-income countries. There are also workforce diversity challenges and opportunities for improvement, drug access and affordability challenges, and as we've been talking about a lot today, room to introduce patient engagement measures and the like. We'll continue to chip away at these and other patient centricity, bioethics, and social responsibility concerns, working with patients and stakeholders to advance measurable progress. And we'd love your help and participation. So please reach out if you would like to get involved. Thank you.
Thank you so much, Dr. Miller, for that insightful presentation and for really enlightening us on the research behind equitably building trust in science, but also patient centricity, specifically for many of our members who are represented by patient groups, also those who are in industry. So this presentation was also just timely, as we heard also from Mr. Nicola Brook, talking about global health equity. So I'm really happy that you brought that to light. So I do have, I welcome everyone to please post their questions on the Q&A box that is located on the Zoom, but I also have a couple of questions so we could start our conversation here. Primarily, I wanted to first start off on, we have many different organizations represented on this call, including, again, representatives on the medical product development community. So how can these organizations collaborate with underrepresented patient advocacy groups and community organizations or industry to build trust?
So the question is, how can trial sponsors build trust?
And collaborate with underrepresented patient advocacy groups?
Mm-hmm. Well, so the science on exactly what builds trust is actually weak. There are a lot of theories and lots of different conceptualizations on what trust is. So one leading definite, so first of all, we all need to agree on what trust is and what trustworthiness is, right? We don't, as I mentioned, we don't just want trust, trust in a used car salesman who sells you a lemon of a car, right? We want trust and we want trustworthiness. So we want merited trust. And one of the definitions for trust is encapsulated interest, right? That I feel that it is in your best interest to take my interest into account, right? An alignment of interest. And that's actually one of the reasons we started the Good Pharma Scorecard, to align interest, right? We wanted to take patient interests and make it in the best interests of pharma companies to account for them, right? So an incentive compatibility mechanism. And so they're getting publicly rated and ranked to incentivize them to take our interests into heart. So that's the big umbrella, right? Encapsulated interest. Pharma companies need to be able to incorporate our patient interests and communicate that we're at the center of their decision making. And then in order to evidence that, we need a series of measures, right? Which is what I've been trying to flesh out. But we, in terms of it, often companies will just ask, like, well, what is the one thing we could do to bump up our trust, right? And I tend to push back and say that's not a very smart or sustainable way of thinking, right? It has to be ethics and trust by design. In everything you do, it has to be the patient at the center. And if you take a one issue sort of perspective, maybe that'll work for like a year, right? So every 10 years or 5 years, you'll see what the media is focusing on changes, right? And so the 1980s, it was sweatshops, right? And so the equivalent to that for the pharmaceutical industry was exploitation, using third world countries to develop drugs for first world needs. It was actually not what the data shows is happening. So it's the opposite. We don't include non-high income countries enough in research. And so there was this big concern about the way that we were conducting trials in non-high income countries. And then, it went to marketing. Companies were spending more on research and developing more on marketing drugs than on research and development. There were all these studies showing it was like double on marketing than R&D, and then they wanted to see that change. And then it was pricing, drug pricing, right? All these are critical issues, but what the media pays attention to sort of changes. And we don't want practices to be, we want practices to be consistent and consistently patient-centered, and not just to shine a spotlight on an issue for, as long as the media is paying attention. So, how can we collaborate with patients? We need to do more focus groups. Patients, what do you need to advance your health from pharma companies? Let's develop measures together. Let's make sure we're benchmarking companies to track progress.
Mhm. So speaking of communication, I know coming from an academic background, oftentimes communicating uncertainty can be very difficult for a lay audience. So how do you recommend organizations and even industry or academia, for that matter, communicate uncertainty in a way that still increases that trust in science?
Right, right. So science is hypothesis driven. I mean, a lot of activists are calling for more health literacy or science literacy in general. But the Pew study showed that we talked about, right, 57% of Americans would be more likely to trust scientific findings and therefore products, right, if we were much more transparent about the research process and data. And as I showed you with all the data, that's just not happening, right? So one key element that is, pretty easy to do is be transparent about the trial protocol, the trial results and everything, and engage patients in the process of setting the research agenda and setting the outcome selection in the trial site locations and every aspect of the protocol development.
So speaking of the Good Pharma Scorecard, where, as you develop this initiative, where do you see this going next?
Well, we're going to publish the diversity, equity, and fair inclusion rankings for clinical trial participants. Where I'd like to see it is, I'd like to see it grow much faster, right? To encompass many more issues critical to patients. Workforce diversity, right? Our investigators and our clinicians need to be much more diverse. The access to products, the affordability and accessibility of approved products. So the ideal goal is within the next 5 years to have a comprehensive scorecard that's looking at all those buckets that were on the screen, right? Everything from when you have an idea about a new product, the questions we're asking, the research agenda we're setting, to how you're designing your protocols, how you're conducting your research, to the marketing of the product, and ultimately to the accessibility.
Okay.
And I would really like investors to start trading on it. I think that would be another lever for change.
Great. And then just the last piece. I know you touched a lot on this during your presentation, but I think it really feeds into the next panel, where we're talking also about diversity in clinical trials. But how can equitable patient engagement increase trust in science and also in patient centricity?
Mm-hmm. I think anytime somebody's included in the discussion and is able to see what's going on, right, it tends to breed trust. It's part of that transparency piece, and we want to be involved. We want to be represented. We want to make sure our interests are encapsulated in everything that's done. And patient engagement is a way for both understanding what the interests are of patients and actually getting them encapsulated into everything that's done within the sector.
Mm-hmm. And I have one final question. Is the Good Pharma Scorecard publicly accessible?
Yes, you can click an ad. Go to www.bioethicsinternational.org. It is on the bioethics website and in the peer-reviewed literature.
Okay. And actually, one more question just came through. So at what level and how do you engage? You were speaking about listening sessions with patients. So is it community and coalition grassroots, or is it, patient advocacy organizations like the headquarters of them?
It's both. It's through the patient. It's everything from our funding. Our first funding came from patient groups, through the decision of what our priorities should be. So everything we do is filtered through patient input. And in terms of who, it's with patient advocacy organizations and patient groups who then reach out to their members to provide feedback. So for example, when we did our priority setting, Susan G. Komen Foundation, I think interviewed 250 or surveyed 250 of their patient representatives for feedback on a couple of questions that we had. So we try and do both. If anyone has an idea of how to do it better, definitely reach out, because it's an iterative learning system. So if you have better ideas, let us know.
Thank you so much again, Dr. Miller. We're right on time. So just again, I appreciate, the conversation, your leadership and your scholarship in this area. And it was very important to remember. So just again, we're very thankful for you joining us today in this conversation.
Thanks for having me and for your great work.
Of course.